abdominal anatomy, and so I've thought around the curriculum and around areas which I think may come up. First thing is I'm going to go through levels, abdominal levels from T11 to L5, because increasingly I think we're expected to know anatomy in a plane manner, in the way of planes, because that's how CTs are. So let's go enlarge this a bit. So here we are at T11. Obviously the most obvious organ is the liver, and this is a contrast image, so we can see contrast within the liver and we can see contrast within the stomach. So at this level we can see the aorta, we can just make out the diaphragm, the dome of the diaphragm, just running around the back of the liver there and the back of the stomach. We can see the spleen. So that's at T11. We haven't got any other abdominal organs other than the liver and the stomach and spleen visible at the moment. Drop down one level to T12, and we're just picking up the top of the left kidney. So the left kidney coming into view first. We've still got the spleen. You can still see the diaphragm quite clearly, and the aorta just in front and to the left of the vertebral column. And of course, we can still see the liver. And we can make out the inferior vena cava a bit more clearly on this view as well. So that's T12. We come down one more level to L1, and now we've got some further details beginning to appear at L1. The gallbladder has begun to appear. We can now see from the stomach passing through the pylorus into the duodenum, the beginning of the duodenum. And then within the loop between the stomach and the duodenum, we've got the pancreas. Behind the pancreas against the vertebra, we've got the aorta. Just in front of that, we've got the beginning of the superior mesenteric artery. And the other structure closer to just slightly closer to the liver than the SMA is the portal vein. So we've got three big vessels there. We can see both of the kidneys fairly clearly, and we can also pick up the descending colon on the left side. So that's the L1 level. And we've still just got a little bit of spleen, but as we go to L2, the spleen has gone. We've lost the spleen. We've got both the kidneys, and at L2, between L1 and L2, we've got the vessels for the kidneys. So here we can see the left renal vein arching over the aorta, and the branches of the renal arteries at a similar level. We can still see the superior mesenteric artery just anterior to the renal vein, because its course runs parallel with the aorta and anterior to it for a significant distance. We can also see the portal vein, and we still see the stomach. We can still see both of the kidneys at L2, and we can still see the liver at L2. If we drop down one more level to L3, we've still got the kidneys, we've still got the bottom of the liver, we can still see the stomach, we can still see some of the duodenum, still got the aorta, and at the L3 level is where the inferior mesenteric artery arises. We can't see it in this particular section, but the inferior comes off at L3. The psoas muscles are becoming more apparent at this level. We drop down one more level to L4. At this level, the aorta divides into the common iliacs, left and right. And so at this level, we've also got the convergence of the common iliac veins to form the inferior vena cava. There's a lot of loops of small intestine visible here, and they dominate the picture here. These psoas muscles are seen quite distinctly against the fat behind them, and that's why they stand out so well on X-ray, because the contrast between the muscle and the fat, the different densities. So that's L4, and then finally at L5, at this level here, again, we can, the points, I'm just going to show a more higher power image of this to pick out some of the structures in this. I'm going to flick to another image here, which is just a magnification of that one. So just in front of the vertebra, we can see the vertebra in the center. The bright round objects that, first of all, there's the common iliac veins, the large structures just touching the vertebrae, then touching that are the common iliac arteries, which are both arrowed. And then in front of those are the two ureters, about 2 to 3 millimeters or so across, and they've run along the front of the psoas muscles, and we can see the big bulks of the psoas muscles either side of the vertebrae, and they're continuing on their course down into the pelvis. And of course, they pass anterior to the iliac vessels, the common iliac artery and common iliac vein. Okay, so that's a quick run through the levels of the abdomen from T11 down to L3 in planes. We just remind ourselves of the anatomy around L1. So L1, obviously there's a certain height to L1, it's quite a decent sized vertebra, and that would run more or less through the center of this image around where you can just see the superior mesenteric artery coming out from within the pancreas with the superior mesenteric vein next to it. And we can see the pancreas and the tail of the pancreas stretching over towards the spleen on the left, and the loop of the duodenum going around it. The duodenum, of course, in this stage is retroperitoneal, as is the pancreas. And we can see the kidneys, and of course we can see that the right kidney is lower than the left. And the way of thinking about that is that the liver on the right, the bulk of the liver, forces the kidney to be a bit lower on the right-hand side. And of course we can see the flexures from the ascending to transverse on the right, and transverse to descending on the left. Okay, and if we just focus for a moment on the aortic vessels, and if we look at the aorta, perhaps if we just focus on the magnification on the right and start at the top. So at about the beginning of L1, we have the celiac axis that comes off the front of the aorta. About a centimeter below that, we have the superior mesenteric artery. And then at about the L1, L2 junction, we have the left and right renal arteries. And then as we come down, we have the testicular arteries, which we can see have a long course. We can see these long arteries stretching down, and they come up just above the inferior mesenteric, which is at L3. And then in this image at the lower border of L4, we can see the aorta bifurcating into the two common iliacs. And we can see just to the right of the aorta is the inferior vena cava, and that the common iliac veins combining to form the inferior vena cava just to the right and behind the right common iliac. Okay, so that's just a reminder, a rundown over the main branches of the aorta that we're expected to be aware of. Because of the importance of the ureters and the points at which stones can become lodged, we're expected to know about the anatomy of the ureters. So this is an image of, in fact, two obstructed ureters. It's not normally possible to see the whole of a ureter because it's peristaltic. You just see waves of contrast moving down. So if you can see the whole of the ureters, it means there's a blockage in this, what's known as a standing column. But this is just a useful one to show the path of the ureters. So the ureters lie just outside the tips of the transverse processes. That's the usual anatomical description. And the points of narrowing are at the pelviureteric junctions. That's the narrowest point, the PUJ, the pelviureteric junction. But then also as the ureters pass anterior to the iliac vessels, as they enter the pelvis. They pass anterior to the iliac vessels, and then they run down into the pelvis before joining the bladder posteriorly in the trigone. So they're posterior to the urethral orifice, up and behind and to the left and to the right. So it's a posterior point of entrance. And I'm sure that'll come up more in the anatomy talk about the pelvis. And here's another image showing that sort of diagrammatically. And as I mentioned earlier, we can see that the right kidney is lower than the left, and we can see the ureters coming down and just being kinked as they go over the iliac vessels on their way down to the bladder, and you can see the opening posteriorly into the bladder. Just to mention the location of the adrenal glands, because that has come up in the exam. The adrenal glands are quite medial. They're superior to the kidneys and quite medial. So they can sometimes be seen on CT. In fact, it may be worth me just going back a few slides to show the adrenals on the CT sections. So this is an image in L1, and we can see in the right kidney, medial to the pelvis, between the pelvis of the kidney and in fact, some of the diaphragm against the vertebra, the white structure there is part of the adrenal. If we go up a level, I'm not sure, we can just vaguely make it out. So that's about the adrenal. Okay, so in this image, we can also make out the celiac axis, then a centimeter below it, the superior mesenteric as well. Now, there's increasing emphasis on ultrasound, and so I'm just going to focus on that for a moment. If you just look at actually the right hand of these two images, the one in pink and blue, this shows the standard positions of the probe when undertaking FAST, focused abdominal sonography in trauma, doing a FAST scan. And we're just looking for specific things. So from the right loin, position number 1, we're looking at the junction between the liver and the right kidney, what's known as Morrison's pouch, looking for free fluid, and I'll show an image in a second. And from that position, we can also see the diaphragm, and we can also see fluid within the pleural cavity above the diaphragm. So those are the things that we're looking for from the right-hand side. Similarly, from the left-hand side, we can see the spleen, and we can see the left kidney, and we can see if there's anything between those. And we can also see the left dome of the diaphragm, and above that and behind that, any fluid in the pleural cavity. From the epigastrium, from position number 4, we can, by pressing down into the abdomen and angling the probe up into the chest, we can see through the membranous part of the tendinous part of the diaphragm through into the heart, through the pericardium and into the heart. So we can see pericardial fluid in image number 4. Also in that image, and one of the ways we orientate ourselves is by looking for the aorta, looking for the pulsatile aorta, which can't be compressed. And then as we scan down the aorta, looking for the superior mesenteric artery, which runs parallel to the aorta and anterior to it as a landmark. Also, as we move up the aorta, to its right, we find the vena cava, and we can then see the branches of that into the liver, the hepatic veins, just before the inferior vena cava passes through the diaphragm and into the right atrium. In position number 3, we look at the bladder, both in a transverse and in a sagittal plane. And of course, the amount that we see depends on how full the bladder is, because other than the bladder, the structures in that area, the small intestine, contain air, and ultrasound won't pass through air. So we need the bladder as a window through to the structures beyond. And we're particularly looking for fluid behind the bladder in the pouch of Douglas, or in a male in the vesicorectal pouch. And we're looking for free fluid and blood there. So those are the positions that we use in FAST, focused abdominal sonography and trauma, and questions could come up about this. So these images here, the left is a normal, the right is abnormal. So in the left image, we can see the liver with the right kidney, and there's nothing between the two of them. But in the abnormal image, if there's free fluid within the abdomen, and in trauma that means blood, we see a dark line appearing between the two, between the liver and the kidney, and that's what we're looking for in a FAST scan. Coming to the subject of the appendix. Now, just to orientate you to this image here, the blue line is the sort of outline of a person, of a female, and then the box in the middle is a superimposed barium study, in which barium has gone right the way around the large bowel and down into the appendix. And they've been superimposed so that we can see where McBurney's point is. Now, McBurney's point is a third of the way in a line between the anterior superior iliac spine and the umbilicus. And it's defined by the fact that if you have tenderness in McBurney's point, then deep tenderness, then there may be appendicitis. So that's the point about, that's sort of the significance of McBurney's point. Of course, the position of the appendix itself is quite variable, and we'll say a bit more about that in a minute. But we can see from this image contrast within the lumen of the appendix, which just shows us how long the appendix is. So this image shows us some of the common positions of the appendix. It's very variable. It's quite a long structure. It averages about 11 centimeters in length. So it's quite a long structure, and it can lie into the pelvis as a pelvic appendix. And of course, if you have a pelvic appendix and you get appendicitis, there may be pelvic symptoms. There may be diarrhea. There can be urinary symptoms because of irritation of the bladder by an inflamed pelvis. Similarly, the pelvis can be retrocecal. We can just make out a appendix behind the cecum, or it can be lateral to the cecum in this paracecal description, and it can be in front of or behind the ileum. So there's a number of different positions that the appendix can be found in. And of course, that means that the inflammation, if you imagine the tip of the appendix being the focus of most inflammation and most pain, you can see the wide range of positions that the tip of the appendix can be in, and hence giving such a wide range of different sites for presentation. This is a normal abdominal X-ray. There's a very slight amount of scoliosis in the spine, but essentially I've brought it up as a normal abdominal X-ray because there could be questions about anatomical detail in plain abdominal X-rays. Of course, X-rays only have 4 contrasts. They show contrast between 4 different densities, which are bone, water, which is muscle and organs, fat, and air. So we have those densities in which we can pick up detail where there's an interface between 2 different densities. As a result, many of the organs within the abdomen which are of water density, we can't see them distinct from each other unless there's air or fat to help us. So in the abdominal X-ray, we should be able to see the psoas picked out by retroperitoneal fat. So we can see the psoas shadows running down here from about L. We can see them really up from the lower border of T12 right the way down to the pelvis. And we can also see the kidneys, and the lower pole of the kidneys is usually visible. And we can just make out the lower poles of both right and left, with the right kidney being lower than the left. Of course, we can make out the bones, so we can see the ribs, and we can see the crests of the ileum, and we can see how the transverse processes of L5 are more or less level with the crests of the ileum. Beyond that, we can occasionally see calcification. Obviously, about 90% of kidney stones are visible on X-ray. Very few gallstones are. There are few of them are calcified, but very few. Occasionally, we can see the pancreas when it's calcified. And the other main use of abdominal X-rays is looking for obstruction. Of course, if the small bowel is more than 5 centimeters, then that indicates that it's distended, and we may see valvulae conniventes, these lines that go right the way across the small bowel, which indicate that it is small bowel. If the large bowel is distended, there may be large bowel obstruction, and there we look for haustra, which only go part of the way across the bowel, and those are a feature of large bowel and tell us that it's large bowel that's distended. And the final subject I wanted to talk about is the lumbar spine, really, and just thinking of things that could be asked about the lumbar spine, apart from the levels. And I think one of the main things that could be asked about is to do with injuries to the spinal cord. Now, the spinal cord itself ends at the lower border of L1, junction between L1 and L2. And beyond there, all the spinal nerves run down as the cauda equina, which means horse's tail. And you can see why from this diagram, because this large number of this sheath of nerves running down in the space and then appearing at their various vertebral levels. And we can see from this why damage to neurological damage is much more common to the cord than it is to the cauda equina. The cauda equina has much more room to move if there's injury to the spine.